Welcome to the World Federation of Neuroscience Nursing's International Meeting. My name is Christy DeLimas, and I'm president of the World Federation of Neuroscience Nursing. As you know, the WFNN was founded in 1969, and now we have 8,800 members across the world. Today's meeting is brought to you by the WFNN in concert with the Canadian Association of Neuroscience Nursing. I also want to take the time to thank our generous sponsors, the Crimble Foundation, as well as the Toronto Western Hospital, Surgery One, LifeShits, and also I want to take the time to thank our planning committee. If you're on the planning committee and you happen to be in the room, please take the time to stand. Beverly Espedito. Oh, okay, so I'll recognize them later. Maybe we'll go ahead and start with our first speaker. Dr. Tator's influence is probably best manifested by his work in prevention, particularly related to sports and recreation. His advocacy efforts resulted in adoption of new legislation and guidelines to prevent spinal cord injury in hockey. In 1982, he founded the Think First Canada, an organization that educates young people about safety. Among his many awards, Dr. Tator was appointed the member of the Order of Canada in 2000 and inducted into the Terry Fox Hall of Fame. Please join me in welcoming Dr. Tator.
Well, thank you very much, Christy. It's lovely to be here. I'm a bit of a ham, so when anybody asks me to speak, I usually say, fine. So I regard this as an opportunity to spread the message, especially among you folks who I have worked with all my life, at least your predecessors. I know how important it is for all of us in neuro to be up to speed on things. And in fact, that's one of the reasons why I shifted up from the spinal cord a few years ago, although I haven't left the spinal cord. It's probably still number one in my research endeavors. But in terms of clinical activity now, I do a lot of concussion work because I recognize that there were so many uncertainties that it was really difficult for patients, for example, to get the treatment that they deserved. So when Dawn asked me to be part of this, I said, sure. I'll be very happy to tell people here what they should know about concussions. The take-home messages are here that concussion is really a team sport. Everybody has to know something about concussions, whether you're a nurse or a therapist or a mom or a teacher, coach, etc. Nowadays, we all have to learn about concussion. That's what we have learned in order to deal with this effectively. So it really is a team sport, and we're still sort of flying by the seat of our pants in that there are a lot of mysteries. There still are a lot of unknowns, but we are getting there. We're gradually filling in some of the blanks. So here's what I do. I mentioned here Parachute Canada. Anybody heard of it? Good. Anybody heard of Think First? It's still around. So Think First was the predecessor to Parachute in terms of injury prevention. And that is one of the things that I would like to stress, that you folks can all play a role in preventing some of these injuries. So here's what we would like to cover in the next half hour or so. We may not get to all of them, but we'll try to touch on most of them, and we'll try to end up telling you about the new concussion law in Ontario, and also something about prevention of concussions. So where does concussion fit in the picture of brain injuries? So in our country, we are very fast living. We drive our cars too quickly. We play a lot of risk-taking sports. Certainly I did, and I still do. But that's the nature of being in Canada. And so concussions are very frequent in our country. How many here, in fact, let me ask the question this way. How many here have had a brain injury? How many here have had a concussion? Quite a few hands. So here's lesson number 1. When you put up your hand the second time only, that was a mistake. You should have put your hand up the first time as well, because what we have learned is that a concussion is, in fact, a brain injury. So it is a mild brain injury. In fact, one of the terms for concussion is mild traumatic brain injury, but I really dislike that term. It has a very long-winded definition, and it doesn't describe a homogeneous group of patients. It's rather heterogeneous under the term mild traumatic brain injury. And when you tell somebody who carries the effects of a concussion, or especially repetitive concussions for the rest of their life, if you say to them, well, you've only had a mild traumatic brain injury, that's not really fair. So concussion is a better term. So we've already done that. And, you know, of the types of brain injuries, it is in fact the most common. And I don't have to remind you about the long list of different types of brain injuries. So nowadays, we don't think of concussion as just being an acute thing that you get over and that's it. Concussion is, in fact, now what we call a spectrum of disorders. Yes, it begins with the acute concussion, but then we have these other consequences of concussion. Second impact syndrome, post-concussion syndrome, the psychological effects, etc. And we'll try to cover all of these. The definition of concussion has really been simplified. This is it. It's an immediate, but usually temporary, alteration of mental functioning due to trauma. So there has to be some physical force involved to call it a concussion. But that physical force does not have to be directly to the head. The physical force can be to the chest, for example, which causes a whiplash effect on the brain. That can cause a concussion. And so that's one of the things that drives concussion people crazy when the lawyer or the judge or the doctor, from time to time, because there are still lots of doctors who misdiagnose this condition. They'll say, well, how could you have had a concussion? There's no bruise on your head. But there doesn't have to be, because the force doesn't have to be directly on the head. It can be transmitted through the body. And in fact, about 25% of people who are concussed also have whiplash of the neck, because the mechanism is the same in many people. It's that rapid acceleration, deceleration of the brain and the head, along with the neck. The old terms, we should not be using the old terms of bell ringer, ding, seeing stars, Those terms were used when we didn't really understand what a concussion is. But if you see stars, if you feel your bell has been rung, that's a concussion. So let's use the modern terminology. We don't understand exactly what happens in the brain with concussion. We don't even know if it's primarily a white matter or a gray matter injury. We know it's not due to bleeding. There's no evidence of bleeding in concussion, and we don't think anything is torn. It's not a laceration. So can you activate this? Yes. So you see the brain moves. Activate it again. This type of acceleration, in fact, is linear acceleration. But the next slide shows what we mean by rotational acceleration, which is like the jiggle of the brain. And that's really what happens with concussion. The brain jiggles inside the skull. And it doesn't take much to cause a concussion in those who are susceptible. The causes of concussion are many. With adults, probably motor vehicle crashes is the commonest cause. With younger people, it would be sports and recreation. With older people, it's falls at home. So depending on the group, that will determine how you get it. And then there are other aspects of concussion: spousal abuse, intermittent partner violence. Concussions are often a major issue. And in fact, a few months ago, we had a specific symposium here on concussions in women and girls. And there are differences between concussions in men and concussions in women. And we'll try to cover some of that. So they are important in sports, not the only type of mechanism that is important, but sports are the way that young people get concussions. And also it's one of the ways in which people get repetitive concussions. And what we have learned is that pretty well everybody, but not everybody, gets over the first concussion, but not everybody gets over 2, 3, 5, 10 concussions, which some of the athletes are subject to. So just in case you think I don't know what I'm talking about when I talk about sports, believe it or not, I'm on this team. I won't trouble you to find me, because you won't, even if I left it up for a half an hour, you won't guess which one is me. But I did play a lot of sports, so I sort of know what I'm talking about when I talk about sports. The features of concussion are here. It's usually a diffuse injury. So, if you find weakness of one arm or leg or a pupil dilated, that is not concussion. There are no focal neurological deficits in concussion. The symptoms and signs of concussion are rather subtle, like vertigo, dizziness, headache, ringing in your ears, sensitivity to light. And there isn't a good way of grading a concussion. We're often asked, well, was it a mild concussion or was it a severe concussion? And in fact, all the old grading systems that we were forced to learn, and maybe you sat down with a book of grading of concussion one time and said, this doesn't make any sense. Well, you were right. It didn't make any sense. And in fact, we've thrown them all out because there is no scientifically accurate way to grade concussion. So a concussion is a concussion is a concussion, and it is a clinical diagnosis. We have identified some of the risk factors. For example, certain activities like hockey, football can cause concussions. We talked about the age effect. The gender effect is definitely there. Women have a higher incidence of concussion in hockey and in basketball, for example. The post-concussion effects tend to last longer in women and girls. We do suspect a genetic factor. Certain families seem to concuss more easily than other families, but we haven't identified what that factor is. And we do recognize that the incidence of concussion is actually going up in our country, and it's still going up. And a lot of that is due to improved recognition rather than actual greater risk-taking activity, greater exposure. But we're now recognizing concussions more. So that's why the graphs are going up. The issue of a biomarker has been in the news for the last couple of years, and every so often a university or a hospital announces, we have a breakthrough in concussion. We have discovered a biomarker. Not true. There's a lot of good research being done to try to discover a biomarker, but we have no reliable biomarker other than you and me. We are the ones who still make the diagnosis of concussion. For example, can you diagnose a concussion with an MRI or a CAT scan? And the answer is definitely not. You can rule out other conditions, but you cannot look at an MR and say, this patient had a concussion. We're not there yet. Maybe we will be there tomorrow. There's certainly a lot of work being done on this. And this is just an example of an MR that's completely normal in someone who's had several concussions. So far, it depends on you and me to make the diagnosis. And this is just a list of tests that have been looked at and are being looked at as potential biomarkers, and this list isn't even complete. So this is how you make the diagnosis. Here are the symptoms. This is only a partial list of symptoms. You know most of these. There are, in fact, about 65 symptoms of concussion, and we have now got about 1,000 patients on our roster where we've carefully documented the type of symptoms they have, and there's pretty well no two patients in that 1,000 who are the same in terms of what symptoms they have. So the variety of symptoms is quite dramatic. The other thing that we have to be aware of is that in many people, the manifestation of these symptoms, the time when they become apparent, is not the same for everybody. They can all be present from the first moments after concussion. So some people immediately, I have a headache, I'm sensitive to light, I feel dizzy, I can't concentrate, et cetera, et cetera. In other people, these other symptoms can evolve over hours or even days. We've seen a few patients where they evolve over a week or two, but most of the time over days if they are going to evolve. So initially they may have headache, sensitivity to light, dizziness. And then 2 weeks later, when you examine them again, they start to say, you know, I'm really depressed. I'm very anxious. My ears are ringing. Why did my ears start ringing a few days ago and not at the beginning? We don't have the answer for a lot of that, but we do recognize that these symptoms can evolve over time. We call that a latent period, and once again, we have no idea why that happens. And then there are a whole bunch of very late symptoms that I'll tell you about a little later. So we've mentioned that recognition is everybody's job. Everybody should know something about how to recognize. We don't expect anybody other than doctors or nurses to diagnose. So recognition is for everybody. That's the teaching now. And diagnosis is usually reserved for medical doctors. But because of the number of concussions that are out there, there's no way that everybody's going to get to a medical doctor. And they do filter into other people, especially non-trained people. So we want nurses to take that job of diagnosing concussion. It hasn't actually been worked out yet. In fact, we just got our concussion law in Ontario a few months ago, and now the issue of access is coming up. And access means recruitment of people like nurses and nurse practitioners to be part of the diagnosis of concussion. So we've said that it's a clinical diagnosis. So that means it depends on an informed expert examiner, like a doctor or a nurse, and it depends on a compliant patient. So we know that a lot of patients lie about this. They don't want to reveal that they've had a concussion. Why don't they want to reveal? Because they know that they're going to be pulled out of the game or practice that they love. So this is a big problem for us to teach youngsters especially to reveal when they have concussion symptoms. We have been aided significantly by international consensus conferences. If we had more definite biomarkers, we wouldn't need these conferences. But in the absence of biomarkers, we have to make people knowledgeable about concussion and define what we're talking about. And that has actually happened over the past 20 years or so. Experts from around the world have been meeting to define better what a concussion is and what it isn't. So we're benefiting from all that's gone on. And in terms of our own country, we have played a significant role in this, and we're one of the first countries, in fact, to have what we call our own national guidelines, which were published just last year. So you can get the flavor that this is an evolving topic. And here are our own guidelines. So they were put together by Parachute, and they are published, and you guys should read them. So it's about a 65-page document. So here's your reading for the weekend. And it has really a lot of information in there, and it'll be easy reading for you, I'm sure. But it's useful information that we should all have. So what's in there? One of the major principles is to remove the person from the current game practice or work environment. And this issue of repetitive concussions doesn't just occur on the playing field. It also occurs, for example, in the work environment. I've treated a few warehouse people or roofers, people in high-risk occupations who have objects fall on their heads, etc., who get this problem of repetitive concussion. So remove the person, if it's an athlete, from the game practice, or if a worker from the environment. Don't leave the person alone. Those are sort of time-honored principles for any brain injury. We used to advocate a longer period of downtime. There was absolutely no evidence that that helped. So we've shortened that downtime to about 24 hours. So stay quiet for about a day after a concussion, and then gradually increase your physical activity and mental activity. The word threshold is important. Everybody has a whole bunch of thresholds after a concussion. So you'll have one threshold for walking. You'll have another threshold for watching TV. You'll have another threshold for using your cell phone. And we teach that you should learn to identify your thresholds and not go beyond that, because that means you are having too much physical or mental activity for your recovering brain. So if an activity produces symptoms, cut back. That's the message. That's an important aspect of recovery. This tool is really not for you. It's too simple for you, but it is useful for parents, coaches, trainers, etc. And you'll find this in that same document, which is downloaded which can be downloaded from the Parachute site. When we talk about return, the return process, it's very important to gradually return, a graduated return. And there are two aspects, when to return and when never to return. So some people should not return to that risk-taking activity. And there are rules for when to tell a player, for example, to hang up your skates, you're finished, with collision sports. Or a worker where we have to say, look, that's not in the cards for you. You have to change jobs. It's too risk-taking to continue. And so we have rules. For example, if there are any definite neurological deficits, such as cognitive decline, that's really important. So I saw a 13-year-old not too long ago who'd had 3 concussions in 6 months, and he was not passing grade 5. So that is serious for a youngster with significant cognitive decline. That kid should never play contact sports again. Return to learn and return to work are even more complex than return to play. Return to play has an organized 6-step process of graduated exercise increase, but return to learn for an elementary school, a high school student, a university student, a nursing student is a very complex process and has to be individualized and has to have accommodations. Delay in the exams, providing greater exam time, deadlines extended. There are all sorts of accommodations that the educational system has actually learned to provide. I'm very impressed with how teachers have adopted this information and ease kids back into the school. And don't forget, there's no help from any imaging or other biomarker. We're often asked about baseline testing. Does it help? My view is no. It doesn't help in the diagnosis of a concussion, and it doesn't help in the management of the return to play, return to learn, return to work. It's very good for the bottom line of the person who's administering the baseline. But other than that, it's useless. It's a waste of time and money, in my view. There are a lot of good concussion websites. How many here do baseline testing, by the way? Anybody here making a living from baseline? Well, you may be offended by my remarks, but that is the current thinking. In fact, Parachute is just putting out a document in the next couple of weeks about baseline testing, which indicates the same information that I've just given you. There are some very good websites, and here are just some of them. The bottom one, Ontario Neurotrauma Foundation, very good information. Parachute, we've already said. And the CDC in the USA is terrific. They were very fast off the mark to disseminate very good information about concussion, very reliable. So what's happened recently in Ontario, we have been very good about trying to deal with this concussion problem. In 2014, for example, we had a province-wide concussion management system recommended for all school boards. In fact, they were supposed to begin implementation in 2014. So that has been a very good thing. So school teachers are now clued in. And what we did this year was to introduce concussion legislation. Now, we are the first in Canada, but we're not the first in North America, for example, because all 50 states in the USA have concussion legislation already. So we're rather slow to pick this up. We don't need to emulate everything that goes on below the border, but some of the things they do are good. And I think they were right in introducing concussion legislation, and now we're following that. And I think it is useful to, as a means of ramping up the importance of knowing about concussion and dealing with concussion more accurately. And I'll tell you how this happened. And this is how it happened. Now, this is one of the consequences of concussion called second impact syndrome, and it actually is a very serious consequence because it can be life-threatening or life-taking, as you will see. What is second impact syndrome? Well, we don't know exactly what it is, but it means that you get another blow to the brain before you have recovered from the first blow. So that's why it's generally known as second impact syndrome. It is also known as malignant brain swelling. It tends to affect young people. We think it may be a loss of autoregulation that is involved, that causes this huge rise in intracranial pressure. It's very difficult to treat. There have been some patients who have had very large craniectomies early on to deal with the swelling who have survived, but most of the time when they do survive, they have significant neurological deficits. And it is completely preventable. So I want you to take that home. And you'll see here, there's a list of people who have been documented in the literature with the second impact syndrome. You see they're all young people, and many of them died. And this is the first case in Canada, published in the Canadian Medical Association Journal many years ago. This was a hockey player. This was the external surface of the brain. Here's the cut surface of the brain, and you see the hemorrhages in the brain stem that produce permanent coma. So he never woke up after his second impact. And this is the most recent case. I hope you know the name Rowan Stringer. because we now have a Rowan Stringer Day, which in fact was just 2 weeks ago in Ontario. And she died as a result of playing rugby. She was the captain of her team, and it wasn't clear why she died just from rugby, but it did become clear at the inquest. It took an inquest to figure out why she died. And the inquest was told that she had a concussion on Friday in a rugby game, another one on Monday, and then on Wednesday she had her final fatal injury, again in a rugby game. And when she was taken to CHEO in Ottawa and had an anybody here from Ottawa? She had an emergency neurosurgical decompression, which did not help, and it was done very expeditiously, and she was declared brain dead, and her organs were used for organ donation. And at the inquest, not until, we learned why she died. And she had texted to her friends about her initial 2 concussions. She didn't tell a single adult. She didn't tell her parents, because they all testified at the inquest. She didn't tell her teacher. She didn't tell her coach. But she did text clearly the symptoms that she had from her concussions. So this led to a lot of people saying, this must never happen again. And we now have Rowan's Law, which came into force just a few months ago. The regulations accompanying the law are being written as we speak. So we don't exactly know how this will play out. For example, there was a committee to advise the government on which I sat for 12 months. And one of the pieces of advice is that nurses should be included in the diagnosis of concussions, or whether they'll follow that, we will see. Or we should see those regulations published in the next few months. So this is what the law says, that it not only applies to schools, it applies to every sport team, like all the Hockey Canada teams, all the Rugby Canada teams. The team that Rowan Stringer played for is now obliged by the law to provide concussion education. And there will be a code of ethics that hopefully will help us prevent concussions. And the law currently says that every year there will be a day called the Rowan Stringer Day, where her memory will be perpetuated and the idea of the importance of preventing concussion will be emphasized. So going on to other aspects, one of the important additional consequences of concussion is what we call post-concussion syndrome. And this is quite a debilitating condition because it can affect a large number of people. The exact percentage of those with concussion who go on to get post-concussion syndrome, we don't know. It's probably about 25%. So 75% recover totally within a week or two. They're up, back at school, etc. But about 25% don't recover promptly. And we are busy trying to figure out why those 25% don't recover, and it isn't clear. And as I mentioned, it can be quite debilitating because they can have a lot of symptoms. Here's one group of 220 patients that we looked at, and the mean number of symptoms was 8. So these people don't just have headaches, they have 8 symptoms. This is really very debilitating. And here's the list of the more common symptoms. And this shows that you can get post-concussion syndrome after only 1 concussion. So these are the patients who get it, but usually it happens after repetitive concussions, after 3, 4, 5 concussions where you just don't get better. And the question is, do you don't get better for a few years, or do you not get better ever? And there are some who never get better. And this graph shows in black those that we are following who are still not recovered, and you can see some of them are not recovered for even 15 years. This is the type of recovery curve that we can generate, and this shows that if you have 17 symptoms after concussion, that's the ones at the top, you're never going to recover. There is no recovery. But if you have only 1 or 2 symptoms, the chance of recovering is much greater. So we are gradually learning more. This one we can skip over. So how do we treat post-concussion symptoms or post-concussion syndrome? And we actually treat it based on the symptoms. And you can see here that for the symptoms, we do have significant therapy. So if they have an accompanying whiplash, we can do something about that. If they have vertigo, we can do this repositioning. If they have headaches, we have good treatment for many types of headaches that can follow concussion. For some symptoms like tinnitus, we have nothing. For mental health disorders that are very frequent in concussion, we have very good treatment. So we have learned quite a bit about treatment. However, we don't have a drug, really, that would prevent concussion. Can a player take something beforehand? No. We don't really have anything that will accelerate recovery, although we do think that treating the symptoms appropriately will get you better faster, but we haven't proven that. So far, prevention is the only cure. So I want to end up in a moment with that message emphasized. Just a word on the mental health issues. They're very common after post-concussion syndrome, depression and anxiety being the most common, and many patients with post-concussion syndrome do commit suicide. And so we've always had that specter hanging over our heads that a certain percentage are going to kill themselves because of the severity of the symptoms. And there may be some reasons for that, because we've identified that loss of inhibition is one of the features of post-concussion syndrome. And so that thought, well, I think I'll kill myself today, actually can't be inhibited, and so they do. So that is a big problem that we have to be aware of. We also have another problem, and that is what is advertised to patients as being effective for management of post-concussion syndrome. And it drives patients crazy to read all this junk on the internet about what's going to make them better. And there's a lot of junk, I can tell you. And this is just a list of it, and a lot of people are making a lot of money on this population of patients. One of the big questions in this field is, does post-concussion syndrome ultimately morph into this condition called chronic traumatic encephalopathy? This is the condition that cost the NFL $1 billion. And we don't have the final word. We have recognized this condition by we in the health care professions for a long time, and it has gone through various names. Some of them are terrible, like the punch drunk syndrome. That was a terrible term to use, to think that they have this brain degeneration because they're drunk, which is completely a misnomer. And it has claimed the lives of many people, including Steve Montador, who I'll show you. So here we do get some help from imaging, and you can see the atrophy of the brain on this CAT scan in somebody with dementia pugilistica, which is what we used to call this, but now we call it CTE. And we know quite a bit about it now. We know that it's the deposition of an abnormal protein in the brain that causes it. Here's a CFL football player for the Ottawa Rough Riders who was 67, and his brain was willed to our project. And you can see this brown material on the bottom left that gets deposited in neurons and damages and destroys those neurons. So this is a very damaging condition. We have tracked it down to this abnormal protein. That's how we identify it. This is Steve Montador, who was a hockey player. He played for 6 different NHL teams. I personally counted the number of concussions that he had just based on doctor's reports. He had 19 concussions. And I'm a friend of his father, and I saw him play, and at the game he gave me this signed photograph of himself that I had in my office. And I told him about our studies, etc. And he said, well, Doc, if you want my brain, you can have it. And so it was very sad when that actually happened. He was found dead at age 35. And his brain is shown here, and the brown gunk in his neurons is very clear. So at age 35, this can happen after repetitive concussion. This is the thing that Gary Bettman says, well, we don't have enough information about it. We don't really know enough about it to say that hockey is causing this. How do we diagnose this condition? So here's another frustration for patients and for practitioners. Currently, we can only diagnose it at autopsy. Can you imagine in 2018, we have a condition that requires an autopsy to make a diagnosis? That's how far behind we are in concussions. But we're working on it. For example, in this hospital, we do a lot of PET scanning. We've now scanned about 50 CFL players looking for how much tau, that brown protein that they have in their brains, because we can now detect tau with a PET scan in a living person. So we're hopeful that at some point we'll be able to detect this during life. Just a message about the young brain seems especially vulnerable to concussion. The emphasis has to be on prevention. Prevention has 3 phases: preventing the concussion from occurring. That's important. That's probably the most important. There's all kinds of things that you can do, that society can do. For example, anybody here play soccer? No? No soccer players. So soccer is played very often now in Canada. Kids should not be heading the ball until they're about 14. And that wasn't the case. We have a lot of kids who got concussion at age 10, 12 from heading the ball. So there's lots of things that can be done. We go to schools. This is me in a school teaching about concussion. We now have a concussion law. This is our concussion research team here. So we are getting there, and it's nice. This is the first time I've used this logo, Crumble Brain Institute. So we now are in a brain institute. And I'm happy to answer any questions for the last 3 minutes.
Thank you so much. Any questions for Dr. Tator?
Hi. So Denise from St. Mike's. I do a lot of work with the head injury clinic at St. Mike's to triage our patients that come in to be EVA'd and discharged home, and then my responsibility is to kind of touch base with them after they've been discharged to see how they're doing and determine what the next best step might be for those folks.
That sounds terrific.
I love it. It's actually pretty cool. But what I'm finding, so on that note, part of that process involves, and you were talking about grading concussion, and you know how there's all these tools that we really kind of have tossed out the window, so to speak. But what's interesting to me is we, in practice, using the Rivermead tool, which, you know, I'd like to kind of hear your opinion on that. But the only reason why you're really kind of employing that tool is to kind of give me a sense of what is it that patient is experiencing on the day-to-day. We usually call them a week out from the date of their injury, at least, to kind of touch base. And it's really just to kind of give me a sense of, as I said, you know, how are they feeling, what are they experiencing, and how has it impacted them? In that context, I wonder how you feel about its use in that way.
I think that's an excellent thing to do, to give you an idea of how that patient is doing. Rivermead is a well-examined tool for grading recovery. So I would say proceed with that. That's terrific if you're doing that. The SCAT-5 for both adults and the child SCAT-5. SCAT stands for Sport Concussion Assessment Tool, is probably the most commonly used tool around the world. I should have shown a slide of it. It's good, and if you're using it in the way that you described to assess how that patient is doing, terrific.